نعم نعم. يلا بسم الله الرحمن الرحيم. The second or the third gland we will talk about today is the parathyroid gland. Parathyroid gland. Any idea about the normal anatomy of the gland, of parathyroid gland, Shabab? How many thyroid glands are present? They are 4, 2 upper and 2 lower. And this is the normal histology. The normal histology of the chief cells and the occipital cells, and also the fat lobules of fat are normally present within the parenchyma of the parathyroid gland. So 2 types of cells, the chief and occipital, and the lobules of fat, and the parathyroid parafollicular C cells within the thyroid interstitium. They are responsible for secretion of calcitonin, which is antagonize the effect of parathyroid hormone. So these cells of endocrine cells of parathyroid gland secreting parathyroid hormone that is controlled. What is the controller? What is the stimulus for secretion of parathyroid hormone? It is not controlled or not under the control of pituitary hormone or releasing hormone, but the stimulus for secretion of parathyroid hormone is the level of or decreased level of serum calcium. Normally it is 9 to 10.5 milligram per deciliter. And when there is hypocalcemia, this is the stimulus for secretion of parathyroid hormone from the parathyroid gland, whereas it is antagonized by the calcitonin effect. 4 in number. Parathyroid glands are 4 in number, 2 upper and 2 lower gland in the posterior aspect of the thyroid gland, 2 superior and 2 from the 4th pharyngeal pouch, and 2 inferior from the 3rd pharyngeal pouch. Normally, or physiological action of the parathyroid hormone, chief cells of parathyroid hormone producing the parathyroid gland secreting PTH, that is parathyroid hormone. The activity or the secretion is and the release is controlled by the free ionized calcium in the blood rather than by trophic hormones from the pituitary hypothalamic axis, and its effect is antagonized or by the effect of calcitonin secreted from the parafollicular C cells. In general, the action of this parathyroid hormone, it acts to increase the blood calcium level by increasing bone resorption, activate the bone osteoclast to resorb bone and increase bone resorption by its effect on these osteoclast-like cells, and to resorb bone and to elevate the level of serum of blood calcium, and also it increases the reabsorption, so bone resorption, and increases the reabsorption of calcium from the kidney, and also increasing the conversion of vitamin D to its active form, alpha-1 dihydroxycholecalciferol form in the kidneys. So increase bone resorption, increase the reabsorption of calcium from the kidney, and activate the conversion of vitamin D to its active form. These are normal physiological actions of parathyroid hormone. There is, keep in mind, malignancy is a common cause of clinically apparent hypercalcemia. Hypercalcemia is in general, hypercalcemia is clinically apparent, and it is a common cause for clinically apparent hypercalcemia, so malignancy, not PTH release, as a result of widespread calcification and due to tissue damage, and whereas the most common cause of asymptomatic, so the symptomatic or clinically apparent hypercalcemia is mainly caused by malignancy, whereas the most common cause of asymptomatic hypercalcemia is primary hyperparathyroidism. Primary hyperparathyroidism, that is without symptoms, and it is discovered incidentally by elevated level of blood calcium. Primary hyperparathyroidism means it is related to parathyroid gland hyperplasia or adenoma or even carcinoma. Excretion of phosphates by the kidney, so will decrease. There will be decrease in serum phosphate. It also, the PTH augment or increasing the gastrointestinal calcium absorption. The net result or the ultimate outcome is to increase the level of free calcium and inhibit, that is negative inhibition for the parathyroid hormone release. Types of hyperparathyroidism. Types or clinical types of hyperparathyroidism. 3 types: primary, that is endogenous to the parathyroid gland; secondary, which is related to renal failure; and tertiary and advanced renal failure also. So in the primary type, primary hyperparathyroidism, the calcium level here is there is autonomous or spontaneous production of PTH by the parathyroid hormone, parathyroid gland. This is independent to the serum calcium or to the blood calcium level. Independent, in which there is an adenoma or hyperplasia. So there is independence to the calcium level, and there is no response to feedback inhibition. The parathyroid gland not respond to normal feedback mechanism. It is mainly related to parathyroid adenoma or parathyroid hyperplasia. laboratory finding. أي سؤال عندكم شباب؟ laboratory finding, there will be elevated calcium secondary to excess PTH release and bone resorption, and all the mechanisms are will be augmented, and low phosphorus. Whereas the secondary type in which there is excess PTH in response to chronic hypocalcemia. In renal failure, there will be impaired renal function, and the kidney not filtered phosphate properly into urine, result in renal osteodystrophy. It's called renal osteodystrophy. So there will be alteration or changes in the calcium and phosphate level. And the secondary type, in the secondary hyperparathyroidism, there will be increase in the serum PTH. This is secondary to renal failure, in which there is decreased renal failure or decreased gastrointestinal calcium absorption. there will be chronic hypocalcemia. So, and as a result of this, there will be release or excess release of parathyroid hormone. The laboratory finding or the changes, there will be chronic low serum calcium, in addition to excess phosphate because of the kidney impaired function or renal impairment. So the kidney cannot filter phosphate properly into the urine, result in what we call it renal osteodystrophy, which are manifestation of bone, including bone pain and bone fracture, secondary to renal failure, hypocalcemia induced by renal failure. So secondary hyperparathyroidism will be result increase chronic release of parathyroid hormone and with associated bone resorption. Whereas the tertiary type in which there is persistence of high parathyroid hormone after correction of secondary hyperparathyroidism. The tertiary type develop in patients with secondary hyperparathyroidism. For many years, secondary hyperparathyroidism, patient with renal failure for many years. So there will be hyperplasia of the continuous hyperplasia or sometimes called autonomous adenoma. هي مو فعلا adenoma وإنما شباب it is continuous hyperplasia, long-standing hyperplasia after chronic secondary hyperparathyroidism for many years. So the patient develop hyperplasia of the parathyroid glands, So there will be continuous autonomous secretion of PTH, parathyroid hormone, unrelated to blood calcium level. So it is refractory or persistent high PTH and elevated level of calcium and also elevated level of PTH because there is failure of response to treatment and failure in patients with secondary hyperparathyroidism for many years. The signs and symptoms. أولاً شباب etiology there are regarding hyperparathyroidism, there are three histological pattern or causes. Single adenoma, either single adenoma, parathyroid adenoma. شو تتوقعون الادينوما تكون multiple or single؟ الهايبربليزيا شلون تكون multiple or single؟ شلون تتوقعون البرزنتيشن in the four glands regarding the four glands شباب؟ So the most common is single adenoma or parathyroid adenoma. نعم.
single gland أو single adenoma ما تكون multiple.
Yes. Usually إحنا قلنا الأدينوما usually single. مو صحيح؟ والبقية the other glands are not enlarged, whereas hyperplasia is generalized. For the four glands. And parathyroid carcinoma is rare. There are certain family history in the primary hyperparathyroidism. نقول primary شباب we mean endogenous cause. Primary means endogenous cause. يعني there is an adenoma, there is a neoplastic process that is secrete excess PTH. This is the most common cause. Single adenoma, neoplastic proliferation in the parathyroid gland secreting excess PTH, non or independent to the level of calcium. So both PTH and blood calcium are elevated. And there is no response to normal feedback mechanism because it is neoplastic cells secreting excess PTH. Hyperplasia and carcinoma are less common. Hyperplasia هذه وين common قلنا وين most common in the secondary type, secondary to renal failure. Risk factors, there are certain family history or of endocrine tumors, or there is a group ناخذ إن شاء الله في نهاية الإندوكراين ونسميه multiple endocrine neoplasia type 1 and type 2. In addition, this is in parathyroid adenoma in addition to pituitary adenoma or adrenal adenoma and so on. And also radiation can cause this type of primary hyperparathyroidism. Regarding the signs and symptoms of primary hyperparathyroidism. شباب احنا قلنا ال PTH parathyroid hormone is uncontrolled by trophic hormone secretion or stimulation. This is stimulated by the decreased level of blood calcium. It can be asymptomatic اللي هو قلنا عليها primary hyperparathyroidism, which is incidental finding or incidental elevation of يعني patient they check for another cause he discover an elevated serum calcium, endogenous production of PTH that is increase the serum calcium, the blood calcium level as a result of the action of PTH, increased bone resorption, GIT absorption, and renal reabsorption of calcium. Or it can be symptomatic, in which the patient develop nephrolithiasis and nephrocalcinosis as a result of hypercalcemia, bone disease including bone pain and pathological fracture, and these are due to increase in bone resorption and even subperiosteal resorption, and osteitis fibrosa cystica, as a result. These are cystic changes or cystic cavities or cystic vacuoles within the bone as a result of excess bone resorption, neuromuscular changes as a result of hypercalcemia, including weakness and fatigue, and CNS causes, including depression and seizures, and also cardiac manifestations or cardiac disorders. We can summarize the signs and symptoms of hyperparathyroidism. As they are called stones, thrones, groans, and bones, and psychiatric overtones. Stones related to excessive nephrolithiasis or stone formation or nephrocalcinosis, increased calcification within the renal interstitium, and renal stone formation. Stones, this is stones. Thrones, this is related to increase in or polyuria and frequent urination. It's related to impaired sodium and water reabsorption. And also groans, muscle weakness and constipation. Bones that are bone manifestation, including bone resorption and bone pain, and pathological fracture due to excess bone resorption and demineralization, and by the action or stimulation of osteoclast. Psychiatric overtones, including depression and mood changes. The morphology of adenoma, parathyroid adenoma, that represent up to 85% of primary hyperparathyroidism, usually or almost always مثل ما قلنا follicular adenoma of thyroid. Also here, adenoma usually single, almost always single, most in the inferior glands and the lower glands in the inferior glands, well encapsulated, well demarcated with pressure compression, and it is soft, tan to red lesion. Most are composed of chief cells with foci of oxyphil cells, هنا شنو اللي اختلف شباب عن النورمال histology? Most are composed of chief cells but often containing foci of oxyphil cells. What is the difference here from the normal histology of parathyroid? What is the difference شباب؟ شنو تتوقعوا شنو اللي يختلف here from the normal histology? The histology of normal adenoma. شوفوا هذه الأدينوما. What is the difference? What is the difference from normal histology of parathyroid gland? Mainly composed of chief cells with foci of oxyphil cells. Any idea? Any idea? Exactly. Little or no fat lobules within the parenchyma. Yes. Okay. This is the capsule or well encapsulation, and this is هذا شنو اللي تشوفوه هنا شباب شنو. This is the adherent or attached thyroid tissue. These are the follicles filled with colloid, and this is the parathyroid neoplasm, mainly chief and foci of oxyphil cells with little or no fatty lobules. Okay. Again, these are the chief cells, نسميها water clear cells or water clear tumor, solid sheets of nests of small follicles with delicate capillaries, capillary vascularity, والفيتشرز الأخرى اللي هي يعني little or scant reticular network, a feature of endocrine tumor. This is a surgical exploration for parathyroid adenoma, usually single, solitary, mainly in the inferior glands. This is the resected or excised parathyroid adenoma. Usually it is solitary or single, not multiple. And this is the location, of the small parathyroid gland, non-neoplastic here. Okay. Regarding the secondary hyperparathyroidism. Again, secondary hyperparathyroidism is related to excess PTH in response to chronic hypercalcemia in patient with impaired renal function. So in patient with renal failure associated with vitamin D deficiency or osteomalacia. Mainly skeletal changes, osteitis fibrosa cystica, and osteomalacia called renal osteodystrophy. Renal osteodystrophy mean bone changes or skeletal changes secondary to renal impairments or secondary to renal failure. The morphology, like as in primary hyperplasia or hyperparathyroidism, the morphology of the secondary type. In the secondary type, it is related to chronic patient with chronic renal failure. So long-standing secondary hyperparathyroidism, result in adenoma. هذا autonomous adenoma. هذه مو, it is not neoplasm, it is it is called or autonomous stimulation or long patient with long standing for many years, patient under renal failure, renal impairment for many years. They develop secondary hyperparathyroidism due to hyperplasia of the thyroid gland. There will be continuous autonomous secretion of parathyroid gland even after correction. The gland will become unresponsive to this correction. So there will be autonomous adenoma. It is called adenoma, autonomous adenoma or autonomous stimulation or secretion of the parathyroid hormone by the parathyroid gland. This is called tertiary hyperparathyroidism. So the primary hyperparathyroidism, there will be high serum calcium and low serum phosphate. The kidney is unable to filter phosphate properly into the urine. The parathyroid hormone is elevated. In the secondary type, the serum calcium is lowered. In patient with chronic renal failure, high level of serum calcium, unable to filter calcium. And this is vice versa. شباب دائما الكالسيوم will acyl phosphate, high calcium result in low phosphate. When there is excess serum calcium, there will be lower serum phosphate. Low serum calcium, the phosphate is elevated here. And also it is hyperparathyroidism. There is excess or stimulation of PTH secondary to renal failure. In the tertiary type, the level of serum calcium is elevated. And in the tertiary type, serum calcium is elevated or high, and the serum phosphate will be varies and associated with high PTH secretion, high parathyroid hormone, and low level of vitamin D. So in the primary and tertiary type, the patient have in the primary and tertiary type, the patient have low or slow muscle contraction and less excitable neuron due to hypercalcemia. Bone resorption and renal osteodystrophy, and calcification of the blood vessels and even soft tissue. شباب اكو سؤال لحد الان عن الهايبرباراثايرويدزم primary, secondary or tertiary? If there is any question, please.
دكتورة بس ممكن توضح لنا التيرشري أكثر؟
Yes, the tertiary, it is a result from develop in patient عند long-standing secondary hyperparathyroidism. قلنا احنا secondary hyperparathyroidism is related to what? The secondary type? The secondary
renal
type?
failure.
Renal failure. Patient with renal failure, long-standing for many years. Patient have many years or renal impairment or renal failure. هذا الشيء يصير عنده هو هسه secondary hyperparathyroidism. شو يصير عنده؟ renal failure. شنو يصير عنده؟ يصير عنده negative feedback، مو صحيح؟ لو due to serum calcium is lower. Serum calcium will be serum calcium in the secondary type. شو يصير عنده؟ يصير عنده low serum calcium و elevated serum phosphate. فش حيصير؟ يصير يصير positive feedback على ال PTH، على ال parathyroid hormone، على ال parathyroid gland to secrete PTH. This will result in what? This will result in يعني in the secondary type. In the secondary, there is excess parathyroid hormone. The renal impairment, there is renal impairment and renal osteodystrophy. هاي قلناها. Renal osteodystrophy اللي هي skeletal manifestation as a result of result in bone pain and increased bone resorption. Patient with tertiary hyperparathyroidism. يعني هو عنده long standing or chronic secondary hyperparathyroidism for many years. هذول البيشنت will develop autonomous adenoma. قلنا هي it is not adenoma by its as a true neoplasm. It is a result from continuous stimulation by the low level of low serum calcium. So there is continuous stimulation of the gland to secrete PTH for many years. Continuous stimulation of the parathyroid gland to secrete PTH to compensate for the lower level of serum calcium with all its manifestations, skeletal manifestation, renal manifestation, and GIT and psychiatric manifestations. So there is insomnia autonomous. So patient with secondary hyperparathyroidism will develop this autonomous secretion of PTH separately from blood calcium level. يعني ما إلى علاقة or independent to blood calcium level. Okay? حتى لو يصير correction، حتى لو البيشنت يعني ينطوي سيرم كالسيوم أو يصير correction للrenal impairment even with normal، يعني حتى من يرجع للنورمال الrenal impairment السيرم كالسيوم when it is returned to normal there will be continuous stimulation of this or كأنما adenoma, as if it is an adenoma. It is not adenoma by itself, but because of long-standing stimulation, there is continuous production of PTH by the parathyroid gland, unresponsive to blood calcium level. So the patient have normal or high calcium, يعني راح يصير correction of normal of the calcium because of correction of renal impairment مثلا by مثلا renal transplant أو مثلا renal dialysis مثلا. The patient have شنو يصير ال PTH level بالtertiary high low normal. It is high. Yes.
هاي دكتور.
Yeah. High with low vitamin D. So patient شلون نعرفه laboratory finding من يصير correction للrenal impairment. البيشنت الكالسيوم حيرجع للنورمال، راح يرجع للنورمال، بينما السكندري لا، secondary low calcium. The tertiary the patient will develop normal or even high calcium. زين؟ with high level of as a result of continuous يعني continuous secretion of PTH by the parathyroid unresponsive to blood calcium level. واضحة هسه؟ يعني هي ال primary autonomous to the or endogenous to the parathyroid gland, most commonly parathyroid adenoma, less commonly parathyroid hyperplasia and carcinoma. The secondary type is related to excess PTH in response to chronic renal failure or renal impairment. من نقول renal failure or renal impairment قبل renal failure can be corrected. Whereas the tertiary type, the patient have long-standing secondary hyperparathyroidism for many years with continuous hyperplasia of parathyroid. نقول hyperplasia, نقول autonomous adenoma. It is not neoplasm. It is stimulation or continuous stimulation. Yani cells are stimulated for a long time to secrete PTH. They are unresponsive to the level of blood calcium. Okay? واضح لحد الآن؟ أوكي شباب؟
واضح.
يعني secondary. Yes. السكندري والتيرشري both of them are related to renal failure. واضح لحد الآن؟ And the secondary type, secondary hyperparathyroidism, there is low calcium and increased phosphate due to failure of the kidney to filter phosphate properly to urine. Okay? واضح؟ Whereas in the tertiary type من يصير correction للrenal function. حتى with this correction, the patient will also have high PTH by the autonomous production of adenoma or hyperplasia. So the patient have normal calcium or even high calcium. Okay? In the tertiary type. شنو كان السؤال؟ شنو قصدك يعني؟ ال نعم. Yes. لا, in the secondary type, it is related to renal failure. أكو renal failure. من يصير renal failure شنو يصير؟ يصير chronic hypocalcemia. The chronic hypocalcemia, it is related to تعرفين الكدني is important or it is يعني it is also يعني have a يعني effect in the level of blood calcium. The patient have and the secondary type تقصدين يعني? Yes, in the secondary type there is يعني الكالسيتونين here is يعني not effective أو الeffect here or the main or the core of the pathology here is excess PTH as a result of it is the patient have hypocalcemia. Patient have no يعني الكالسيوم بالسكندري تايب هو low ومو عالي حتى يعني يتأثر بالكالسيتونين. It is يعني it is low. ليش low؟ يعني بالبيشنت ليش يصير عنده low كالسيوم بالرينال فيلير؟ شنو قلنا؟ patient هو عنده renal failure, renal tubules شنو شو تسوي؟ يعني normal renal tubules they are reabsorb calcium. إذا أكو renal failure أو renal impairment there is no reabsorption of renal of calcium. Okay. So the calcium level will be affected. The calcium level will be lowered. مو لأن أكو renal impairment ماكو reabsorption of calcium. مو صحيح؟ الكالسيوم is lowered. الفوسفات is higher because قلنا الكالسيوم عكس الفوسفات. The kidney cannot excrete phosphate properly in urine. وتطلع هاي الفيتشرز اللي سميناها renal osteodystrophy. Osteodystrophy skeletal changes من اسمها renal osteodystrophy. Osteodystrophy خلوها ببالكم skeletal manifestation as a result of chronic hypocalcemia secondary to renal failure. Secondary to renal failure هاي اللي سميناها bone pain, bone changes, osteitis fibrosis cystica اللي هي cystic dilatation أو مو dilatation وإنما يعني due to excessive resorption of bone there will be cystic spaces or vacuolation of the bone as a result of chronic hypocalcemia of renal failure. أكو سؤال آخر شباب؟ الفيتامين D is also lowered. vitamin D will be lowered in the secondary type لأن الكدني أيضا لها role in conversion of vitamin D to its active form. So low calcium, increased phosphate and low vitamin D. Okay. سؤال آخر نتحول على الهايبوباراثايرويدزم. Okay شباب. The hypoparathyroidism. Hypoparathyroidism, when we say hypoparathyroidism, عكس hyperparathyroidism. Low serum PTH. The serum PTH is lowered, whereas the serum calcium is what? When you say hypoparathyroidism,
High
hypoparathyroidism.
level of calcium.
Hypoparathyroidism. Laboratory result. There is less or decreased production or underproduction of parathyroid hormone, decrease in bone resorption. Bone resorption will be decreased. Serum calcium reabsorption also will be decreased. And so the effect of PTH will be lowered and serum calcium will be hypocalcemia, yes, as a result of decreased bone resorption, and hyperphosphatemia, and also features of increased cell excitability as a result of hypocalcemia. There will be tetany, paresthesia, seizures, and arrhythmias. ايش تتوقعون الكالسيوم excretion is increased or decreased calcium excretion? Yes, hypercalciuria. No effect of PTH on the renal tubules to reabsorb calcium. So there will be hypercalciuria. The ECG finding here in hypocalcemia, there will be prolongation of QT interval and long straight ST elevation, ST segment elevation, normal T wave and long QT interval. Whereas in the hypercalcemia, there will be short or abbreviated ST segment and short or normal QT interval. The causes, what are the causes؟ ايش تتوقعون شباب؟ قلنا هسه most common cause of hyperparathyroidism هو شنو هو most common cause of primary hyperparathyroidism? What is the most common cause of primary adenoma? ايش قد البرسنتج؟ ايش قد البرسنتج؟
95.
أي تقريبا إلى up to 85%. Up to 85%. Well, less common causes of hyperparathyroidism, less common types.
كارسينوما دكتور.
لا hyperplasia وبعدين الكارسينوما. Yes, hyperplasia and carcinoma. Here in hypoparathyroidism فشي كلش كمان ايش تتوقعون هو شنو؟
دكتورة ثايرودكتومي؟
Yes, exactly. incidental أو نسميه iatrogenic. يعني شنو iatrogenic؟ يعني هو الطبيب يسوي. Iatrogenic means surgical removal. من دا يشيل من يسوي thyroidectomy for any cause, for colloid goiter, for tumor, for Hashimoto, يشيل وياها يرفع وياها glands, parathyroid glands, 4 glands. يصير هذا السندروم يصير result in hypoparathyroidism or can be congenitally absent or autoimmune disease مثل أي autoimmune disease مثل الهاشيموتو مثل autoimmune adrenalitis مثل any autoimmune inflammation. Okay, but the most common one خلوها ببالكم is surgically induced or iatrogenic hypoparathyroidism. The manifestations or clinically the patient have increased neuromuscular excitability due to reduced serum level of calcium, so features of hypocalcemia. Cell excitability, increased cell excitability, neuromuscular excitability, perioral tingling, oral tingling, paresthesia, tetany, muscle cramps, carpopedal spasm of the hand at the wrist joint, laryngeal stridor, and convulsions as a result of hypocalcemia. Mental changes, including irritability and psychosis, intracranial changes. There will be calcification of bone and calcification of lens, dental abnormality, prolonged QT interval. Okay. So the most, put in mind, that is the most common cause of PTH reduction or hypoparathyroidism is surgically induced changes. Okay, Shabab, I will shift to the pathology of adrenal gland. I will stop share this